Hello, my name is Jeff Hauk, and I'd like to acknowledge my collaborator Ruth Chimenti, who worked with me on many of these studies and has performed some of these independently in her postdoc work. The topic of this talk is insertional Achilles tendinopathy, biomechanical considerations and implications for treatment. Much of this data was presented at the APTA Combined Sections meeting 2017. There are three basic elements of insertional Achilles tendinopathy: the tendinopathy itself, bony abnormality, and retrocalcaneal bursitis. So the hallmark of insertional tendinopathy is pain and deformity around the insertion. We can see in this radiograph the abnormal growths and deformities, that one of which is called a Hagelin deformity, that could potentially impinge on the Achilles tendon at its insertion site. We also remember from our anatomy that between the bone and the Achilles tendon is a retrocalcaneal bursa, which can become inflamed. So it's important to recognize that different than non-insertional tendinopathy, this isn't just a tendinopathy that shows growth and abnormal tissue responses in the tendon, but some of that tendinopathy is being caused by abnormal compression with the bone, and then some of the pain that's occurring in patients is coming from inflammation of the tendon, which is responding to that compressive stress. Here's a typical sample of participants, and the thing that really stands out when we look at this will be the increased BMI, which is not typical of a non-insertional tendinopathy, and the age. So we can see here is that these participants are older, an average age of nearly 60, and their BMI is 30, which is in the overweight to obese range. And so this suggests the possibility of tendon overload as a function of weight rather than activity. The other thing to note is the increased disability with insertional tendinopathy is nearly 50% on the VISA-A, which is likely lower than what you would normally get with a non-insertional tendinopathy, and that patients do very well with surgery, and nearly 50% in some prognostic studies end up choosing surgery as a therapeutic option. So this is some data that we've recorded in comparing ultrasound and radiographs in patients with IAT. We see here is that we found that involved side osteophytes using ultrasound measurements were larger than the uninvolved side, and that there was a correlation between the length of the osteophyte and their pain and severity. So what this brings up is it's possible that during rehab we may not be able to get full recovery, partly just because there's too much bony growth either in the tendon, and we can see an example here where you look at the bony ingrowth is in the middle of the tendon, or at the insertion that is irritating or limiting the ability of the tendon to remodel. So we also wanted to look at the tendon response in vivo, specifically at the junction between the calcaneus and the tendon. And so Mark Buckley's lab, working with Ruth Chimenti, we see here an air bladder was used to passively put the foot into plantar flexion and dorsiflexion while recording ultrasound measures of the tendon stretch. And from that, elastography was used to define two regions of interest, a superficial and deep section of the tendon. And here we see the calcaneus shadow. So we're recording directly from the region of the tendon that's involved in IAT. Two types of strain were recorded. One was compressive and one was tensile. And we can see here the controls are in white and the IAT is in black. And both types of strain indicate less deformation. And so from this, the hypothesis is that the tendon itself that is undergoing less deformation to load, meaning it's becoming more responsive to compression rather than tension. So this was followed by removing tissue um, from surgery. When that tissue was available, they were able to take it to the lab and test it in an instrumented testing machine. So here we have peak strains, and here we have stress versus strain, and the red is IAT and the blue are controls. 0 is at the top here, and so we note that the IAT, which is in red, for each cycle was deformed less per load than the control participants, meaning it's more stiff. The stress strain curve shows us the same thing, where we have less deformation here per load than the control participants. So this confirmed the idea that the compression against the bone is causing metaplasia of the tendon to differentiate into cartilage-like tendon and calcium deposits, which explains the bone ingrowth within the tendon. Now, interestingly, we took also, Dr. Chimenti and myself also took a different look at the tendon response, where we evaluated the stress strain curve of the whole tendon from the musculotendon junction to the insertion. And when we look at that, we get a different answer. And so here's a force length curve for a typical participant. And we note here is a control participant, and we have a nice stiff response to the external load. With the IAT participant, it's much more compliant or less stiff. So we know there's much more deformation to the same load as compared to controls. So how does all this fit together? We have compression with metaplasia, this increased stiffness due to cartilage, but then we also have a whole tendon behavior where it's more compliant. So the theory is that the impingement itself causes a local reaction that's adjacent to the calcaneus, which makes the tendon more stiff, but that increased stiffness also causes stress shielding within the tendon, which may unload the healthy tendon. And in addition to that, disuse caused by the pain may also increase the compliance of the tendon. So locally the tendon's stiff, but globally at a whole tendon level, the tendon is more compliant. So it's our job clinically to stop the transverse strains that are resulting in the impingement and the remodeling, and then to use axial strain to cause the tendon to remodel toward handling axial stress better. So the second thing we wanted to kind of flush out was whether or not the common impairments that drive our clinical treatments were different. And so here what we're looking at is muscle length, whole muscle length, because we often prescribe stretching, and then how that was interacting with impingement at the junction of the tendon and the posterior calcaneus. So we used 3D instrumentation and a controlled load to evaluate non-weight bearing supine knee, ankle dorsiflexion with the knee flexed and extended, and then we also used a lunge test. So the supine dorsiflexion readings showed no difference between the IAT participants and the healthy participants, suggesting musculotendon length of the triceps surae muscle was not affected by IAT and that it was not contributing to IAT. The lunge test showed us some difference. There was a different amount of dorsiflexion with the knee bent and flexed, but we think that might be more due to pain, and here's why. First of all, the supine tests weren't significant, and they were a more controlled load, so the foot motions weren't involved. And secondly, pain was highly correlated to the lunge test, and so was the VISA, which wasn't true of the supine position. And so it's likely that pain, rather than limited length of the musculotendin junction, is driving the lunge test dorsiflexion restrictions. So secondly, we also wanted to look at the influence of the part of the motion that the person's using when they move. So we have the people perform the stair ascent activity. You can see it here, and so they have peak dorsiflexion when the opposite toe is making contact with the step. So we looked at peak dorsiflexion during stair ascent, and we took the ratio of that peak dorsiflexion and divided it by the peak lunge test dorsiflexion. Okay, we see here is a chart of the static lunge test dorsiflexion, the dynamic stair ascent, and end range dorsiflexion. So there were no differences during the motion with peak dorsiflexion during the step. There's the values, but there was a difference between the percent end range flexion used in the IAT and the controls. They used nearly 13% more of their available range of motion, suggesting it may be more important to stop impingement or the part of the motion that they're using during movement than it is to try to increase their tendon length. And that, supporting that concept, there was a positive correlation between the percent end range motion they used, the patient's pain, and their VISA-A score. And we can see the VISA-A correlation here, meaning the more percent of the motion that they used. So here we have people that used over 50% and they're up into the 80, and here 100%. Their VISA-A scores were nearly 0 or quite severe. So in conclusions for these, when we evaluate musculotendon length, there's really no argument supported for stretching. The better argument is to stop the impingement, is to use heel lifts, shoe wear, and motor control strategies to stop the impingement or control the transverse strain that's occurring in the tendon and causing that differentiation into cartilage. So we also looked at the strength and power the person's producing during the stair ascent task. You can see here that there's the decreased, the blue is the IAT and the orange is the controls, and there's clearly a significant decrease in the ankle power that the IAT participants were able to produce, and that power was correlated to both VISA-A and pain, meaning that essentially the less power they were able to produce, the more pain and disability they had. So what this suggests to us is that a key strategy to limiting that impingement with the percent end range dorsiflexion the person's using is how their ankle plantar flexors are performing. And so we thought this is a good strategy for us in terms of minimizing or decreasing the excessive ankle dorsiflexion that could occur during movement. And we know that people with IAT are not usually sports people, so we may have to start with low-level plantar flexion activities, and that's illustrated here by Ruth, who she's using an isometric plantar flexion task that's seated that patients can perform at home, and then progressing to high-intensity progressive resistive exercise, and then getting those to be incorporated into functional movements is a good strategy. So what do we do in training? So our first goal is to stop the transverse compression that's occurring at the junction of the tendon and the calcaneus. So we use shoe modifications, and we see our cowboy boots a good strategy. We have a large heel. and so the person's in slight plantar flexion, which should help with limiting the impingement. And then if the retrocalcaneal bursitis or the irritation is significant, we may have to have them do things like when they go down steps is take one step at a time, not do any kind of hill walking, and limit things like squatting down from the floor to get things and stuff like that. And so this is a strong treatment for limiting and quieting down the irritability associated with insertional Achilles tendinopathy by stopping that compression. So the second strategy would be to cause tendon remodeling. And we know that from a recent paper by Bayer et al. 2015, American Journal of Sports Medicine, that heavy slow resistance 3 times a week is equivalent to the Alfredson training protocol. And we also note that high loads are indicated for returning people to walking and running. And here's an example of how high the loads would need to be. So we have here walking, and here's the moment generated in Newton meters, and it's normalized to body weight. So here we have an average moment for walking is 2 Newton meters per kilogram, and for running it's 3 Newton meters per kilogram. So we would argue that in order to functionally return people to control their dorsiflexion, we need them to have strengths that either are equal or exceed this. So here's an example of the types of programs that we're using, and this work was done by Dr. Cuddyford in his heavy load eccentric training for non-insertional Achilles tendinopathy, but we've experienced the same positive outcomes in IAT participants. And essentially what the program looks like is the peak loads are quite high, and in this example the peak load over the 10-week exercise program reached 400 pounds in one participant, which was the equivalent of 3 Newton meters per kilogram for his involved side, meaning he reached the same level as people would be expected to use during running. So the argument for this is we have people raise up on 2 legs and lower on 1, and what we're looking for is they can't really concentrically get up onto the 1 leg without using the assistance of the other leg. And so by doing this, we're tapping into the increased force production that they're capable of producing with an eccentric contraction, and then getting to loads that they need to be able to produce during a task like running. So the program is done 3 times a week, up to 8 reps per set and 3 sets per session. And as soon as people are able to do 8 reps, they then increase the weight to try to drive their peak load to several times body weight to achieve these equivalent loads that we would normally experience during functional tasks. What we can see here is some of the outcomes with we have just one subject represented 2 here. So subject 2 had several years of AT. They had a VSA-3 of 63. They had achieved this very high load state over the 10-week period, and they had a 30% decrease in tendon width and no tenderness to palpation at the end of the testing, and an increase in their VSA beyond a minimally clinically important difference. So that positive outcome was typical. We can see here across 6 participants there was overall 21% decrease in tendon girth in response to this high load 10-week program. So the other part of our strength training involves the foot intrinsic and extrinsic muscles. This is motivated by data that we published on heel rise height. We can see this graph is the angle, the mean change in angle that's associated with the midfoot, and here's the mean change in angle that's associated with the ankle, and the purple is young, green is old, and the blue is posterior tibial tendinopathy patients who have very severe flat foot. But we can see in all cases, to achieve their peak height, they needed equivalent amounts of midfoot and ankle motion, suggesting that this achieving heel rise height is not just a function of the ankle itself, but is also a function of what's happening at the midfoot. So because of this, we include midfoot exercises for our patients that are trying to improve their heel rise height or plantar flexion power. This is an example of how that might benefit people. And so here we have people with severe flat foot, an average of 9 on the foot posture index, that are undergoing a 4-week training program, and we're measuring their outcomes before and after. The 4-week training program includes doming or short foot exercises, therotubing exercises seated to maximally load the posterior tibialis muscle, and a standing trunk rotation while maintaining doming. And what we can see here is the outcome was from pre-intervention to post, the foot pressure readings, and then here on the far right we have the control participants. We can see that there's the post-treatment reading is better than the pre-treatment in terms of normalizing their foot pressure, but still not quite equivalent to the controls. So this is significant improvement in foot function during a dynamic test like walking, in addition to the increased number of heel rises that was significant, even though the participants did no calf work, is impressive. And the average number of reps that increased in heel rise across the 8 participants was 8, suggesting that the improvement in heel rise ability was not trivial. We include no stretching because there's nothing indicating that would help these individuals. And finally, we leave you with some thoughts on referral or advice for patients that are going for surgery. Here's a picture of the surgery that people undergo at our institution. We have here you can see the deformities here, pre-surgical, that potentially could be abutting up against the tendon and causing some tendon breakdown. And then here, post-surgery, that's removed. Also the abnormal tissue that's cartilaginous now or inflamed is also removed and then resewn and reattached. So it's a fairly significant surgery, and what we have been doing is taking preoperative patient-reported outcomes, notably the PROMIS, physical function, pain interference, and depression scales, and then following them for 7 to 12 months, and then looking at how many of the patients improve with surgery and how many do not. And we define improvement as a minimally clinically important difference. And what we can see is preoperative scores here that predict a minimally clinically important improvement. So the patients who are 95% likely to reach that minimally clinically important difference, we can identify them significantly by physical function scores that are 2 standard deviations below the average for the U.S. population, and pain scores that are nearly 2 standard deviations above. So what does this mean? This means that their preoperative status, in order to know that they're going to do well with surgery, needs to be fairly severe functional deficits that are only a few people, 5% of the U.S. population experience, and pain that is similar to that, where very few people experience pain that high. And when they have those physical patient-reported subjective outcomes that they're experiencing, they do very well with surgery. And so what this is highlighting for us is that our decision to have people go to surgery needs to be mitigated with some kind of concrete information that's associated with their functional and pain deficits. So what's likely happening currently is that patients with annoying symptoms but not severe may also be choosing surgery and may be somewhat disappointed because the surgeries themselves don't actually restore us to 100% function, but just take patients back to the same level they are before they just have surgery. So in order for patients to really experience a positive benefit for surgery, what this is telling us is they have to have very significant losses of physical function and pain that's inhibiting their activity. Well, I hope this helps you treat your patients. Thank you for your time, and here I acknowledge the collaborators from the University of Iowa, George Fox University and Oregon, University of Rochester Medical Center, and Ithaca College. Thank you.